So this talk is being given on behalf of Dr. Dror Mirov, who could not make it to the conference for personal reason. And therefore, I wanted to focus the talk on, I think, what he would say. So I incorporated a lot of his publications into this talk. And I've had the privilege of spending some time with Dror in Tel Aviv and seeing their program up close. So I think I have a bird's eye view on this. Disclosure, again, I have some pending patents related to anti-Müllerian hormone. Okay, there's an estimate that there will be about 1.6 million new cancer cases in the United States in this calendar year, and about 600,000 deaths. You can see the breakdown here by gender of the patients that are affected, and you can see that in women, probably breast cancer is the most common. Also, we know that there will be approximately 16,000 new cases in adolescents and children this year. So this brings us to the cancer and fertility crossroads. And we know that cancer survival is improving, and because of increased emphasis on quality of life and improvement in our fertility preservation options, there's an increasing need to inform patients about their options and the risks from fertility from cancer treatments to their fertility. This is a very important recommendation that came out back in 2006 from the American Society of Clinical Oncology, which recommended that informed consent should be obtained from patients prior to cancer therapy that should address the possibility of infertility, and that this should be done as early in treatment planning as possible. We know that parenthood in cancer patients is possible. We know that about 66% of women who are under the age of 35 who survive cancer will become mothers. That's lower than in the general population, which is 79%. We also know that they're at an increased risk for having a child with low birth weight, preterm delivery, and increased risk for perinatal mortality. This is a recent study that was published looking at women in their who were treated for cancer before age 30, comparing their pregnancy and live birth rates to those of their unaffected siblings. And we can see that their fertility is generally decreased in comparison to their age-matched siblings. And so this implies that this is not a genetic factor, but in fact is related to the cancer or possibly to the cancer therapy. We also know that pregnancy after cancer does not trigger recurrence, and that includes after breast cancer. We know that growing follicles may be damaged by chemo and radiation, but that primordial follicles are often spared and can produce healthy eggs 6 months to 2 years after exposure to the chemo. And we know that chemotherapy can affect the heart and the lungs, and therefore for patients who are going to be considering pregnancy down the road, it's important to assess for these end organ injury before they conceive, because those problems can become unmasked during pregnancy. We also know that birth defect rates in children born to cancer survivors are similar to those in the general public. And there does not seem to be any unusual increased risks for genetic disorders like Down syndrome that have been identified in their offspring. We also know that there is no unusual cancer risk in their offspring, with the exception of true genetic cancer syndromes that are inherited. And this is a slide that underscores those points. We know that different kinds of treatment have different risk for sterilization, and probably the highest risk comes from total body irradiation and drugs like cyclophosphamide and procarbazine, and other drugs have lower risk, as outlined on this slide, cisplatin being intermediate risk, for example, and drugs like methotrexate and 5-FU having somewhat lower risk, and some drugs we don't know much about their risk of sterilization. Dr. Goldman discussed the concept of follicular burnout after chemotherapy, and briefly, it's been demonstrated that it's due to the activation of these various pathways that were discussed following destruction of growing follicles, and you have loss of suppression by AMH and other hormones, and this leads to activation of this pathway and recruitment of more follicles. And so that brings up the concept of pharmacotherapy to protect the ovary. We know that we might be able to perform an individualized risk assessment for patients based on their starting ovarian reserve, the age of the patient, and the toxicity of the treatment that is planned. So taking these factors into consideration, prospectively, we may be able to risk stratify and come up with a individualized sterilization risk from the treatment that's planned. And so these are a few papers that underscore this, and you can see that women who are exposed to radiation, for example, the older the patient, the less radiation it takes to sterilize her. And here we see the same concept with chemotherapy. Again, the effect of age and the different types of therapies that are administered, and how that can affect the risk of ovarian failure in these patients. Here we see the same thing for dose of procarbazine that's given to lymphoma patients, and the time and the age at which the patient is exposed, and then the time that it takes for her to develop ovarian failure afterwards. So all of these things can be incorporated into counseling the patients prospectively. So we know there are numerous fertility preservation options that have been developed, and we've heard a bit about these. These include embryo banking and banking of oocytes, but emerging technologies like ovarian strip or ovarian cortical strip cryopreservation is certainly an option now, and I will talk a bit about that. And for men, we have sperm cryopreservation and even testicular tissue cryopreservation, especially in prepubertal boys. Those are considered experimental options, the ovarian tissue and the testicular tissue cryopreservation. There's also pharmacotherapy, and in GYN oncology patients, there's the possibility of fertility-sparing GYN surgery, which I'm not addressing today. So this shows you the mechanisms and sort of the ways that you can achieve a pregnancy, or the way that you can protect the ovary at various stages. And you can see that pharmacotherapy acts here at the time that the toxic agent is administered, whereas mature cryopreservation, embryo cryopreservation obviously require IVF to achieve a pregnancy. And we'll discuss briefly, but there are various different pathways that cryopreservation of ovarian tissue can lead to a pregnancy, either through in vitro maturation of follicles and subsequent fertilization of those oocytes, and then implantation of that embryo, or retransplantation of the ovarian tissue directly. And we'll talk about a few developing techniques as well in a bit. Probably this is the most important slide in the talk, and we should view the use of GnRH analogs now as the standard of care. This is a very recent meta-analysis of randomized control trials in breast cancer patients, and it showed very clearly that GnRH analogs reduce chemotherapy-induced premature ovarian failure. Very strong statistical effect, and patients who do try to conceive later on have much higher pregnancy rates. So GnRH analogs have really been established as the standard of care, and I think we have now level 1 evidence in support of these. Embryo cryopreservation has been around for many years, as you all know. It's important to understand that the live birth rates are, depending, of course, on the patient's age, the number of embryos that she's able to bank, and can range anywhere between 20 to 40% per 2 to 3 embryos. There are a number of things that limit our ability to cryopreserve embryos. The patient has to be medically stable. It takes time to cryopreserve these. We need availability of either partner or donor sperm, and she needs to have adequate ovarian reserve to be able to produce sufficient egg numbers. We have to stimulate her prior to systemic cancer treatment, and this can be concerning in patients who may have hormone-sensitive cancers. Things like natural cycle and letrozole stimulation protocols have been developed, but these have relatively low egg and embryo yield, and that can be problematic because of the relative inefficiencies of IVF. These are IVF results from cancer patients, and this is a nice review article from Dror Mirov's group. And you can see that cancer patients seem to produce similar egg and embryo yields as non-cancer patients that are age-matched. And you can see that the egg yields range between about 9 to 14 eggs on average, and the embryo yields range between 6 to 5 to 7 eggs, thereabouts in that range. So, realistically for a patient, that's not a lot of eggs or embryos. So a lot of these patients might need multiple cycles to really have a good chance of taking home a baby from cryopreserved embryos, and even more so for eggs. And as has been discussed, the experimental label has been lifted on mature oocyte cryopreservation. And we do have some data. Most of it comes not from cancer patients, but for patients who are electively cryopreserving oocytes for various social reasons, as was just discussed. We can see that live birth rates that have been reported, in support of lifting this experimental label were reported as around 38 to 35%, again, mostly from European groups. And I think, as the prior speaker pointed out, vitrification has been clearly demonstrated to be superior to slow freezing for oocytes. But you can see from this meta-analysis that live birth rates are quite low, even for very young patients. So what this shows us is that you need to freeze quite a lot of eggs. And this is again, for patients who are pursuing elective oocyte cryopreservation, not cancer patients. But I found this very helpful. This comes from the Shady Grove group, Dr. Doyle et al. And you can see that they're showing all the relevant parameters: the patient's age, how many oocytes she's going to vitrify and warm, and how many children she desires. And so they calculated probabilities from this. And you can see that even for very young patients who just desire one child, you need to really cryopreserve a very large number of oocytes to give her a high chance of taking home a baby from those. And so many patients will require 3-4 cycles to achieve such a high number of oocytes, which they may or may not have that ability if they're undergoing cancer treatment. And so this is the real-world data from SART for 2014 oocyte cryopreservation. We actually don't know whether the majority of these cases are cancer patients or patients who electively banked their oocytes, but my guess is it's the latter. And you can see that unlike the studies that were presented in support of lifting the experimental label, the live birth rates here are quite poor. Even in the youngest patients, what's being reported to our national body is 22%, and that's out of 210 thaws. In older age groups, pretty much nobody gets pregnant. So it's important that we look not only at clinical trials, but at real-world data when counseling our patients. Because remember, the clinical trials are performed in centers of excellence, and we're not all doing thousands of cryopreservation cycles. So a more typical clinic will not necessarily achieve the same results, at least with modern technology, and that's changing, as we'll discuss later on. That brings us to ovarian tissue cryopreservation, and this has various pros and cons in comparison to IVF, and I'll just focus on the latter. The pros for ovarian tissue cryopreservation is that it has a relatively low complication rate. It's suitable for all patient groups. There's virtually no delay in cancer therapy. No hormonal stimulation is required, and it can be done before or after chemotherapy is administered. We'll talk about the post-transplantation success rates, but most of the evidence suggests that they're actually pretty good. And not only can it help restore fertility, but it can actually help restore ovarian endocrine function post sterilization. The cons, of course, is that it's an invasive procedure. A laparoscopy would be required, and if you're going to retransplant the tissue, a second surgery may be required down the road. And there's always the risk of minimum residual disease in the ovarian tissue graft, and there are various strategies to mitigate this risk. So, as I discussed before, there are multiple potential routes to use ovarian tissue that's been cryopreserved to achieve a pregnancy, and there are more developed techniques like transplantation of that tissue, which can lead to a spontaneous or an IVF pregnancy down the road, or at the time that the tissue is processed, aspiration of immature oocytes can be performed with subsequent in vitro maturation, and if sperm is available, fertilization, or if not, then you can potentially cryopreserve oocytes. But also there are developing techniques which include isolation of primordial follicles for subsequent in vitro maturation. We heard great talks from Dr. Telfer and Dr. Albertini on this, and finally, down the road, we might see the development of an artificial ovary that seems to be years away. So what are the steps involved in ovarian tissue cryopreservation? Well, the first step, of course, is tissue harvesting, and there are different techniques that have been used for this, and this is all stuff from Dr. Mirov's work. You can see that people have taken little circular biopsies from the ovarian cortex, and some people have taken, large chunks of the ovarian cortex, or even the whole ovary. Subsequently, the ovary is cryopreserved, and majority of the pregnancies that have been achieved to date have been through slow freezing. Remember, it takes the cryoprotectants; they have to penetrate the tissue, and with vitrification, this has not been worked out quite as well, but there are groups that are working on vitrification of ovarian tissue. But so far, I would say that the majority of pregnancies have been from slow freezing. And subsequently, there are various different techniques for transplanting the ovarian tissue graft after the patient has been hopefully cured of her cancer and is in a stable enough medical condition to conceive. This is probably the most common technique, at least the one that's used in Israel that I saw with Dr. Mirov. There are, of course, various different issues that affect how viable your transplant is going to be, how good your graft is going to take, and that depends on pre-surgical issues like the patient starting ovarian reserve, the volume of tissue that's obtained, the thickness of the graft, the processing of the tissue, and the freezing conditions. And then, of course, issues related to the transplantation itself, the ischemic period, the site, how good the vasculature is, the operative technique that's used, and the variety of other environmental factors. So to date, we have at least 60 documented live births from transplantation of frozen thawed ovarian cortex, and this was recently published about a year ago, and I think there are even more cases now. So this is still considered an experimental technique, but I would expect that this will change in the very near future. So the key points from my talk are that fertility preservation options are often neglected in young cancer patients, but there are established and emerging techniques that are available. Fertility preservation requires a very detailed, informed consent process, and it's essential to have direct communication between the treating oncologist and the reproductive specialist. Thank you.